Syncope. 1. The approach to the patient with syncope begins with a careful clinical history and physical examination, which can often suggest a specific cause. For example, syncope in patients with hypertrophic cardiomyopathy typically occurs with exertion. An examination may demonstrate the typical murmur associated with dynamic left ventricular outflow tract obstruction. Syncope with exertion is also typical of patients with the long QT syndrome, LQT1 in particular, aortic stenosis, pulmonary hypertension, mitral stenosis, coronary artery disease, and idiopathic ventricular tachycardia. Patients with subclavian steal syndrome may present with syncope after arm exercises. In atherosclerotic stenosis of a subclavian artery is present proximal to the origin of the vertebral artery. Retrograde blood flow through the ipsilateral vertebral artery, enhanced by exercise involving the affected arm, can induce cerebral ischemia. Auscultation over the supraclavicular fossa may demonstrate a bruit caused by the subclavian stenosis, and the blood pressure is usually diminished in the affected arm. Vasovagal, neurocardiogenic, syncope occurs after a sudden unexpected pain, an unpleasant sight, sound, or smell, prolonged standing, or a stressful situation. This common form of syncope is characterized by the abrupt onset of hypotension with or without bradycardia. Carotid sinus hypersensitivity is manifest during stimulation of the carotid sinus baroreceptors, and syncopal events in patients with this disorder may be associated with head rotation or application of pressure to the carotid sinus with shaving or wearing tight shirt collars. The physiologic response to carotid hypersensitivity syndrome can be cardioinhibitory, e.g., marked bradycardia, vasodepressor, e.g., decrease in blood pressure in the absence of bradycardia, or mixed. Left atrial myxoma is a rare cause of syncope. Symptoms may be positional as the tumor shifts and transiently obstructs the mitral orifice.